Hey guys, welcome back to the Foam Frat podcast. This episode, I got Cynthia with me, and we're talking all about the gallbladder and the biliary tree. You know why? Because we don't talk about that enough. Like, it's not ketamine, it's not airway. I posted this blog, and it got not a ton of traction on it at all. And I immediately knew it wasn't going to get traction because who likes talking about the gallbladder and, you know, the common bile duct? Nobody likes talking about that stuff, but it's actually pretty fracking interesting. Yeah, you like talking about it, especially right now. But I took the blog and I made a case presentation, and I wrote this talk called When Gallbladders Attack. And you've seen me do this talk before, and we've nerded out on some of the ultrasound findings and the ultrasound modification of the Murphy sign. And so what I thought is I'm just going to take it and make it into a blog. So that way, when I do this talk for the Foam Frat refresher course, I can say, hey, if you're interested in learning more, check out this blog. So I've been slowly turning all of my talks into blogs. And I think this stuff is really interesting because my thought process on what happens when somebody has a gallbladder attack, finger quotations, was completely wrong. And that's kind of how I framed that talk, is this is what I thought a gallbladder attack was, and then this is what it actually is. And gallbladder attack's probably not the right term for that, but in that same vein, you just recently went through a gallbladder attack. So what happened with you?
Oh, it's so embarrassing. So it actually happened twice before I actually realized what it was. When it happened, I was at work and it was in the middle of the night. We got a call and I kind of woke up and I had this pain in my right upper quadrant, right upper side. And I kind of thought oh, is that a gas bubble? Is that a cramp? What's going on?
Did you put your butt in the air?
No, but I actually thought I had lifted the stretcher wrong, or I'd opened the door wrong. And I thought I'd kind of pulled a muscle because I've been working all day. And kind of blew it off. It lasted an hour or two. And I just remember thinking oh, I kind of feel nauseous. I don't feel good. And then maybe lasted an hour, went away. Because I tried a lidocaine patch, and I tried ice and Tylenol. And so I was oh, it's nothing. And then there was a third time that it happened, and I was at work, and I was in so much pain. And I remember thinking I don't know if I pulled something. I don't know if it's my gallbladder or my aorta's rupturing.
But it was going away? It was coming and going?
This time it didn't go away. So it would come and go away. It happened twice where it lasted an hour.
Yeah.
And I thought oh, I don't know, cramps, gotta poop, who knows? But it went away. So I thought, not a big deal. Right. And so then it happened for I think it was 3 hours. I was at work and I was sweating, and I tried a heat pack. And I remember I tried roll, and it was in the middle of the night, and I tried rolling over in bed, and I tried everything. And then finally I got to the point where I was okay, something's really wrong and I can't focus on anything other than this pain. And I don't know if I'm going to be good for patient care right now. So I need to go get help somewhere. And I thought, okay, maybe a pulled muscle. That would be the little thing, right? And then I thought gallbladder or aorta rupturing, right? Because we take your AAAs all the time. I don't know. I'm not a smoker,
but you have ultrasound. You have your own personal Terrason.
Right. And so I had ultrasounded myself, and I could see stones, but I didn't see anything that looked or I saw sludge. I thought it was sludge.
Sure.
So not an actual, I didn't think it was a stone. I don't know. I guess I was tired. I was in pain. But I didn't see anything that looked like acute cholecystitis. So I was it's not that. And so, so I ended up leaving work and went to the ER, where I saw one of my colleagues. Actually, it was the doctor who worked before me. So that was super embarrassing. So I'm hey. And he's aren't you supposed to be at work? And I was yeah, I'm dying. And the truth is, all he gave me was Toradol, so Ketorolac, so liquid NSAID, which is nothing, right? And I felt better. And then they did a formal ultrasound, and saw that I had gallstones. So,
yeah. So here's what's interesting. So I remember thinking, all right, a gallbladder attack. My thought process, when somebody has biliary colic pain, that means that stone is lodged where the bile leaves the gallbladder, because we know it's made in the liver, it's stored in the gallbladder, and then it gets I say ejected, but it's probably not as violent as that. It gets secreted out, and then it goes down into the duodenum through the common bile duct.
Or duodenum, yeah.
So I looked it up before this podcast, and it's
Yeah.
duodenum, but I always want to say duodenum.
I say duodenum. I don't think it matters. It's like centimeter,
I
centimeter,
I know, but
tomato,
it
tomato.
is centimeter unless you're an idiot. No, I looked it up and it is duodenum, and I looked at 3 different YouTube pronunciations.
Oh, so if it's on the internet, it's got to be true.
All right, you know what? Anyway,
I'm just
my
messing
thought
with
was that the stone obstructs it, and then like you keep like you got all this bile in the gallbladder that's wanting to contract and like go into the common bile duct, but it can't, and then it just keeps getting bigger and bigger and bigger. But then I was like, well, why would it just go away then? Like people are like, oh, I get this really bad pain after I eat a fatty meal because it's got to go down and break out the the fats, the bile, and then it goes away. And so I remember thinking, like, how is it going away? Like, where's all that bile going? Is it getting absorbed back into the liver? Like, what's going on? And in my head, what I was thinking of this gallbladder attack was actually caused by something called colicolithiasis. And so when I started putting this talk together, the word lith just means a stone. And then once you get into the itis, it's the actual inflammation. And usually those are the patients that have they need surgery right away if you get the itis aspect of it.
Mm-hmm.
And so the colicolithiasis means you got a stone in there, and then the gallbladder contracts around it, and then that causes pain, and then that eventually goes away.
Okay.
But then when that stone makes its way out of the gallbladder and actually into that cystic duct there, then that's when you get the cholecystitis. Am I understanding that right?
Well, you can actually, yes, that's right. But you can also get cholecystitis if the stone is, it can even be trapped at the neck of the gallbladder, like not actually into the cystic duct yet. It can just block it. And I think that's probably when people have like acute short pain episodes.
Gotcha. So it can block.
It's like holding the wall shut, right? It's like putting a doorstop.
And then, but that bile there, that bile can't get around the stone then, right?
Correct.
So then what does it do? It just keeps getting bigger and bigger? Just gets inflamed?
Yeah. But the thing is bile is not like it's not like pee in your kidneys. Like it's not building up that fast. It takes a long time to like fill up your gallbladder. Like it's always
But the gallbladder's contracting around it, right?
Yeah.
So when it contracts around it, that's what increases that pressure and causes the inflammation.
Yes. That, and then and you get like all these like inflammatory cells that come in that like something's not right, and they keep like irritating everything, and stuff starts to swell, and then you have more pain.
Yeah. So then if that stone makes its way into the common bile duct, which is where like you have like your hepatic ducts and your cystic duct lead to, and then eventually the pancreatic duct, if it makes its way into the actual common bile duct and it's just there, then that's called colidocolithiasis.
Correct. Colidocolithiasis.
Colidocolithiasis. Am I saying that right?
Yeah, no, you said it right. So it's stuck in the CBD.
Yes. And what would that patient present like? Like what would they be complaining of? Could they be not complaining of anything?
No, it's usually the exact same thing, actually. So they'll complain of right upper quadrant pain. I'm trying to think, every patient I've ever had who's had a common bile duct stone or even cholecystitis, I mean, they present the same, really.
Okay.
Like it's right upper quadrant pain, usually goes to your scapula in the back. It's like an achy pain that just is constant. And really, I mean, they both can present the same. And you differentiate it mostly by ultrasound, by looking at that common bile duct and seeing if it's dilated or not.
All right. And so then the common bile duct gets pissed off and it starts getting inflamed. And then on top of that, you don't have the stuff draining from the common bile duct into the duodenum or duodenum. And so the things draining would be like the bilirubin, like the aged red blood cells, the waste, your lipase, amylase from the pancreas, depending on where it's at, if it was really low, but usually those are probably fine. But that bilirubin and the bile starts to build up. And what I thought was super interesting is that, it dumps off into the duodenum, which is like where the stomach and the intestines really meet. And that bile has like a bacteriostatic property to it that prevents bacteria from ascending into, moving up into that cystic duct. So if you block that duct and you don't allow that bile to come down, it almost makes the environment more suitable for that bacteria to move out of the intestines and then move into it. And that's where we get the name ascending cholangitis, or acute ascending cholangitis, where it's actually moving into the cystic bile duct. And I was wondering, like, how does it get past the stone? I mean, I guess bacteria is super small, so it doesn't have to like take the path of least resistance. But does it actually just like go around the stone, the bacteria?
Oh Lord, I have no idea.
Well, did you ask the bacteria? You're a doctor.
I didn't ask them. No, but it probably does. I mean, bacteria are like little minute, like little things, and the stones are irregular in shape, so they can probably like sneak through a little bit.
That's true. Yeah, that's true. It's not like
and
a
then
perfectly
you probably have
round...
a lot of like contracting.
Yeah, and that's where this patient gets super sick, right? And so that's what the patient in my story, Miss Catherine, that's what she presented with, is something called Charcot's triad, or really Raynaud's pentad. What's that?
Charcot.
Is that how you pronounce it?
I don't know. That's how I've always said it. Charcot's triad.
I YouTubed it before. No, I'm just kidding.
Stop using YouTube as your source.
You have to understand something. I was not taught any of this stuff in paramedic school. So all of this stuff is me reading books and trying to guess what it sounds like.
That's awesome, though. And you know what? If you probably went to another school, like if I went to another school in New England or something, they probably say Charcot. I don't know. Charcot.
All right, Charcot's. You're right. The T is silent, like the P in toilet, right? All right, Charcot's triad. You're trying to get it. You get it now? Okay. Yeah. So that is a patient that presents with right upper quadrant pain, fever, and jaundice. And the reason they're jaundice is just because their bilirubin's elevated because they can't drain it into the duodenum. And so it starts to accumulate. And I always think about, like, when a baby comes out and they're really jaundice and they say like, oh, after they have a couple bowel movements, it'll all go away. So they're passing that red blood cells through the intestines and or the dead red blood cells. Yeah. So, and then Raynaud's pentad is you add altered mental status. I don't know. Maybe I'm saying that wrong too. Mental status, and then and you add in hypotension as well. And that's really like the entire systemic inflammatory response to that. So that's how it kind of progresses, right? I mean, these all have to start off in the gallbladder, right? Or no? Okay.
No, they all start in the gallbladder. Yes, that's where the stones like form.
Okay. Yeah. And then it just works. Yeah, that's true. I don't know where else it would come from.
Who knows? But no, yeah. So they form because there's that bile stasis in there.
So it's just sitting there.
So yeah, it's just sitting there. And so what's interesting is I just read about like common risk factors, like people who get this, and I think I got mine because of rapid weight loss. Is the big thing. And what I read about it was that your gallbladder is constantly like contracting if you're eating high fatty foods and like lots of calories and big meals. So your gallbladder's always like, building up that bile, building it up for years, right? For like 40 some years, however long I was more overweight. And then you lose the weight. And then all of a sudden your gallbladder's like, hold on, wait, we're still holding all this stuff. Like when are you gonna eat them fries, or when are you gonna have that Culver's, right? So it's waiting. It's still building up, and it's still letting it out every now and then, but it's like not as much. And so all that cholestasis, all that bile stasis starts to form foam frats. It starts to form stones.
Form foam.
Foams. And so I think that's probably why I have 51 little babies in there, or did.
How many?
Because all that 51. I counted 51. In that
51 stones.
Yeah, I mean, there might have been more, but yeah, I counted 51 little ones in that
Santa
picture
Claus
that my surgeon gave me. Yeah, and they were tiny, and the only reason I got it taken out was because I had a lot of doctors telling me like, oh, these are the size that get stuck and can cause gallstone pancreatitis, right? When they block everything and can lead to all that horrible like ascending cholangitis and colidocolithiasis.
Yeah, you sent us a picture of your gallbladder, I think, too.
I know you're looking for it now. It wasn't. I mean, it's what my surgeon gave me. It's not the best picture, but it's like the
Well, so what does EMS need to know about this? Like, obviously, like if you don't have ultrasound, even if you do, you may not be proficient enough to nail this diagnosis. But if somebody says they have right upper quadrant pain and it came on after eating a fatty meal and it's not going away, like you should suspect it. But is there any like medications, like pain medications that work better than others for that? Like you said, you got Toradol. I likely would give fentanyl. Is that cool? Like,
Yeah, I think fentanyl's okay. I think man, I should have looked this up before we started talking. There's something about
well, you've been
how
a doctor for a
I
while
know
now, so
I
whatever
think you
you're
should
doing is
avoid morphine for this.
yeah. I remember they
God,
say you want to avoid morphine because it can cause biliary spasms, or not
yes.
biliary.
Uh, I know what you're talking about. Biliary.
What's the word that sphincter of Oddi? No,
Yeah, no, that's right. So it affects the sphincter of Oddi, and
yeah,
it causes it
Odie, not
to,
Oddi.
maybe contract. Maybe contract. I don't know. But I've given patients who have who ended up having cholecystitis. I've given them morphine before because I hadn't thought of gallbladder, and they were fine. So
Yeah,
I honestly don't think
and
it
really, I
matters
think
that much.
all analgesic medications can cause that. Like,
Yeah,
if
all
I remember
analgesics
right.
could do that. Just kidding. No, I actually do say analgesic, but you can say analgesic. That's fine too. Did you YouTube that one?
Analgesics. Okay. Anyways, moving on. So here's my question to you. Like, let's say I have a patient that I suspect they have ascending cholangitis. Like maybe it's a scene flight, they're jaundice, and their family's like, they normally don't look like this. And they have hypotension and they had right upper quadrant pain. And I'm like, oh man, like this patient is getting septic quick, because when that starts to pressurize in that hepatic area, like those hepatic ducts get pressurized, I think of it like taking a bag, like a saline bag of bacteria, and spiking it and then like running it into somebody's veins, because they get bacteremia, they get rigors, whatever. And they get septic super quick from that. So here's my question. Like, let's say I'm dropping off a patient and I go, Dr. Griffin, this is what we have. We have a patient that, is jaundice. They got a fever. They're hypotensive. They're tachycardic. And so we started a cefepime on them. We gave them, 2 grams of cefepime. What would you be like, you son of a gun, you didn't get cultures first? Like, how do you feel about that?
Oh, I think you have to take it with a case by case basis. I know that I usually get an email or get in trouble if I don't get cultures beforehand. But to be honest, you're trying to do the best thing for the patient. And if they're that sick and you have the opportunity to give them antibiotics, I think it's okay. I think what's actually more important with that whole scenario is that you tell the nurse or the physician, whoever you're signing off to, that was what the patient was having. Like they were having right upper quadrant pain. Like they were really hurting on that side. Like they've had this before. They thought it was their gallbag. Because at that point, that patient's already going to be like Q signing out, not making much sense. Like, like not really talking. So the Q sign, just tongue
And
out.
be like,
so,
hey, they're not normally jaundice.
Right. Well, things like that. I mean, yeah, any jaundice is bad. But just having that history, because the patient's probably not going to be able to tell us at that point if they're hypotensive and altered. And the family, who knows if they're allowed in the hospital or if we're going to get, talk to them or if they're even around. And so getting that part of the history really kind of helps me narrow down my differential. So, yeah.
Cool. No, that makes sense. And I'm guessing cefepime wouldn't be your first go-to. You guys probably wouldn't use like a cephalosporin. I'm guessing you would go with Piptazo.
Cephin. Oh, yeah,
okay.
and Piptazo for sure. Yeah, probably something stronger. But I honestly, if you got cefepime, give it. I think it's fine.
Yeah. Awesome. Well, Cynthia, thank you so much for coming on. This was very entertaining, and as it always is. And I appreciate your expertise in this area. So maybe we'll do a follow-up. You should do a follow-up blog talking about diagnosing this with ultrasound, because you're the one who taught me that in order for it to be a stone, it has to like cast a shadow. Remember when I sent you that ultrasound because I thought it was a stone, and you're like, well, normally they cast a shadow.
Yeah.
Like an anechoic
Well, I don't even
shadow.
know if I don't know. I couldn't really find my own. I don't know if I'm that good at it, but yeah. But I think I was also sick and I wasn't feeling good, and I was like, oh, I don't see anything.
Is that a foam frat shirt you're wearing there?
Yeah.
Oh,
representing.
Wow. Look at that.
Yeah.
Awesome. Well, Cynthia, have a fantastic night. Fly safe, and we'll talk to you soon.